Okay, so I think we'll get started. Good morning, everybody, and welcome to the UBC Health Collaborative Health Education Symposium, Going Rural, Enhancing Practice Education. My name is Victoria Wood. I'm the Assistant Director of Strategic Initiatives at UBC Health, and I'll be moderating the session today. I'd like to start by thanking you for your presence, engagement, and commitment to enhancing capacity for quality of rural and remote practice education. I'd like to start by recognizing that the symposium is supported by the Ministry of Advanced Education and Skills Training and UBC Health. And I'd like to thank and acknowledge all the program partner delegates and the support team who've worked hard to make this symposium a truly successful one. Our development partners are the professional programs at UBC, the School of Nursing at the University of Northern British Columbia, the College of New Caledonia, Northern Health, the Rural Coordination Centre of BC, and Northern and Community Partners. We actually have a broad range of partners represented here today, so I'd ask you to please take a moment to change your Zoom display name to include your partner group. You can see how that could be listed on the slide there, and that way we can use that as a way to kind of get to know each other. I'd like to acknowledge that UBC's Point Grey campus is situated on the traditional, ancestral, and unceded territory of the Musqueam people, and the Okanagan campus is situated on the territory of the Silks Okanagan Nation and their peoples. I'd also like to acknowledge that rural health education and collaboration activities take place on Indigenous lands throughout British Columbia, and I acknowledge the traditional owners and caretakers of these lands. Many of you are joining us from places all over the province, and I invite you to use the website native-land.ca to identify the territory on which you're situated and post in the chat where you're joining us from today. And now I'd like to welcome Elder Cheryl Schweitzer from the Slaxton Nation to begin our event.
Adi, Bandara Hunzu. Unesti wasakto Cheryl Schweitzer Shahatni. I guess on in Gez Dakar Asli Glasden with then in Gez Lucilia Disto. Sakane says K in Gez when is the I and Gwas when is the I is so tight. Good morning. My name is Cheryl Schweitzer. I'm carrier and of Dakar from Glasden. Lately, Snatch Aliad, no Yankat, so I live here in Prince George, lately Tene territory. And now I'll say a little prayer in my language, and then I'll translate it. So, Owen Domodi to Cha, Yisosin, Nekaman, I, Etkawa, and it's in. Seti Testicha, Misaticha, Yasole Bicha, Wacho Dalte Chicha, Manicho Aloud, and Creator, you have given us another day. Therefore, we ask you to help us with our work, our thoughts, our words, and our learning, and everything we do. And Dohone, all my relations.
Thank you so much, Elder Cheryl, for starting us off today in the right way. I would now like to welcome Dr. Ray Markham to say a few words. Ray is Special Advisor to the Vice President Health on Health Systems, and he's also the Executive Director of the Rural Coordination Centre of BC, right?
Thanks, Victoria. And just to echo your thanks to Elder Cheryl for opening us up in such a good way and for welcoming us. I'm beaming in from the village of Valmont, a traditional territory of the Carrier and Simp people, and where I've been practicing as a GP for coming on 20 years or so now. Here mainly in my capacity as a special advisor on health systems, and which really works under the Office of the Vice President to help address the complex challenges affecting healthcare and the health and well-being, kind of learning from our First Nations partners, trying to move into kind of more of a wellness model of individuals, communities, and societies. UBC Health's ultimate goal is to address inequities to improve the system and foster and support healthcare. I'm a physician in a rural community, and so obviously have am particularly vested in that whole thing. And I really believe that the way that we educate our providers of the future across all health disciplines actually does play a role in addressing these inequities on a whole bunch of different levels. UBC Health facilitates collaborations across disciplines, faculties and campuses, as well as communities, institutions, and government organizations. And this symposium is one of those mechanisms to do that, to facilitate dialogue. So a lot of listening and kind of sharing of a variety of perspectives. And that's actually what we really aim for, is a diversity of perspectives from our partners, really looking towards how we improve the way we train people, develop knowledge, and really have people that serve the communities that we all live in. There are lots of challenges facing the delivery of healthcare in rural remote areas of BC, obviously growing populations, aging, diversification, the digital divide, all of those kind of things. And they're larger, as in any kind of system issue. We all know that they're amplified. Any challenge in the system is amplified at the edge, which rural is one of those edges, and there are a number of those other of those edges in the system. So we are really trying to get healthcare professionals and graduates to meet the increasing workforce demands of these places. So student enrollment in health professionals grows, but numbers of supervisors and students in rural remote communities decline. So really, how can we kind of thread that needle of actually supporting education in those communities and the resources that are required to do that? I've been in Valmont for around 20 years now. And one of the things, so I see Carl on here, he comments, one of his kind of phrases is, you've seen one rural community, you've seen one rural community. But one of the things that all rural communities are good at is doing the best we can with what you have, which means that we work in teams because we have to, not because we're smarter or anything like that. So it's a brilliant place, I think, to train people in teams. You know, I've, as anybody who's worked in a rural community, kind of you do what you need to do at the time. So I've made beds, I've fetched meals and put in chest tubes all on the same day. And that's true of all of our teams. Kind of you do what you can. We flex within scope to serve our patients. We've got a resident here in the building at the moment, 2 medical students. We train nurse practitioners and nursing students in our community. I think it's a brilliant learning environment. Recently, one of our residents was on call with me. She landed up in the same evening, putting in a dislocated shoulder, putting in a dislocated hip, dealing with kind of complex chest trauma, all in a supportive team-based environment. So really, how can we kind of get more and more of that happening, where we get people trained to serve and trained in those environments? Over the past year, UBC Health has been working with health partners to develop a framework for rural education, acceleration, and collaboration in health, which is REACH, which is the focus of today's symposium. REACH is intended to connect health students with high-quality rural and remote clinical placements, as well as support preceptors in providing strong mentorship to students. I'm really happy to be a part of the symposium, really appreciate everybody signing on here, which has brought together a diverse range of health partners who have vested in enhancing the delivery of practice education in rural remote areas of BC. And I look forward to the discussion that we're going to have and the collaborative opportunities that I anticipate coming out of this. I'll now hand over to Carrie Krakowski, UBC Health Practice Education Manager, to get us started with a presentation on REACH.
Good morning, everyone. I'm joining you today from the Musqueam territory. I was actually born in McBride, lived in Belmont, and moved to Click territory in Prince George. And then now I'm residing in the Lower Mainland. I'm going to just share my screen now. Okay. All right. So my role is Practice Education Manager at UBC Health, and I was the project manager of the REACH Action Framework development. Thank you so much to Victoria Wood, Elder Cheryl, and Ray Markham for starting us off. And thank you very much, Elder Cheryl, for that, that very welcoming and respectful prayer. I'd also like to thank all of you for joining me in the opportunity to dialogue and accelerate action for rural practice education. I'm going to provide you with some context behind the REACH project and why the REACH Action Framework was developed. And then I'll highlight some strategic directions of the framework and open it up for questions. After a short break, we'll go into small groups and talk about how to move this work forward. Groups will report back on priorities, and then we'll talk about next steps and wrap things up. Rural Education Acceleration and Collaboration in Health, otherwise known as REACH, is conceptualized as a collective of partners with an interest in practice education and a commitment to collaboratively enhancing the capacity and quality of rural practice education. I recognize all of you are passionate about this work, and thank you for joining us. The project was funded by the Ministry of Advanced Education Skills and Training Work Integrated Learning Grant to enhance the rural practice education ecosystem and graduate readiness for the rural healthcare setting. UBC Health was honored to steward the project with guidance from an advisory panel and partner engagement. The main outcome of this project is the development of the action framework. Between April 2020 and October 2021, the REACH project team organized several consultations with stakeholders in the form of workshops, focus groups, case studies, and interviews around the development and usefulness of a REACH action framework. The symposium today is really a continuation of that engagement, and it aims to highlight the needs to take action now and increase the visibility of rural practice education, frame the approach, as well as catalyze individual and collective action and sustain the momentum. We have an opportunity to build networks of people and resources, and we welcome you to do that today. I will share the REACH framework, and which includes a broad range of actions for better assessment, design, implementation, and monitoring of rural practice education. As Ray mentioned, there are many challenges facing the delivery of healthcare services in rural and remote areas. Much of you have your own stories about this. It's rapidly growing, aging. Populations are diversifying. We have a lot of movement in rural areas with industry, and there's a combined shortage of healthcare professionals. These communities really need healthcare professional graduates to meet their workforce demands. But while student enrollment in health professional programs across BC continues to grow, the numbers of preceptors and students in rural and remote placements don't keep pace. Rural preceptors seek more support and training to adequately supervise their students. And currently, post-secondary institutions do not coordinate placements or preceptor supports across disciplines, programs, institutions. And this creates silos, inefficiencies, and some redundancies. After all, 40% of our health professional training occurs in the community, but proportionally fewer health professional students complete rural and remote training. Why now? Well, we have momentum. We need to grab it. There's an increased focus by the BC government on a comprehensive rural healthcare retention program for targeted communities and occupations. A stable rural healthcare workforce means that there are more opportunities for trainees to access experience, supervision, and rural learning experiences. The BC government also has a robust planning coordination of health education and has announced the establishment of a provincial practice education coordinating committee, which will provide recommendations on system-wide student practice education priorities. It comprises of the Ministry of Health, Ministry of Advanced Education, healthcare organizations, and post-secondary institutions. Health professional programs are expanding too and adding distributed models to extend their impact across the province. And UBC Health has committed to work with colleagues and partners to identify ways to support the health of all people in BC through inclusive and coordinated engagement. So now I'll shift gears a little bit and talk about the development and the fine-tuning of the REACH action framework. This development progressed through an iterative process informed by the literature, environmental scans, in-person workshops, and advisory committee meetings where we met for updates and discussions, and engagement with various stakeholders through key informant interviews and 11 focus groups, which included preceptors, students, and community. We talked to a lot of people. COVID gave us some restrictions in terms of meeting with people face-to-face, but we leveraged virtual technology to help that engagement. We also had an opportunity to test an interprofessional student placement project that leveraged virtual technology and local health professional coaches, which I see on the roster today. Thank you for joining us, and community members within the context of COVID. The long duration of this collaborative work and the additional challenges imposed by COVID-19 pandemic provided all the partners with time to reflect on, innovate, and validate the relevance of various aspects of the REACH action framework. The REACH action framework followed a set of guiding principles that was influenced by the advisory committee, and these principles prioritize a shared responsibility towards health equity, flexible innovation, cultural safety, and importance of relationships and collaborative approaches as fundamental to enhancing rural practice education ecosystem. The principles highlight the roles of communities, health organizations, practitioners, post-secondary institutions, and learners within the 4 themes. Please note, communities include patients and industry and government, local government. They recognize that rural and remote practice education is unique from urban placements. It's situational and it requires flexible innovation, as Ray mentioned, and the involvement of communities and a real get down, put both hands in and help out the team. This framework incorporates the tenets of a partnership pentagram, which is considered foundational as a framework for socially accountable health professions education and systems change. So what did we find? I'm going to go over some high-level findings. You're going to have an opportunity to read a more detailed discussion about the findings in the final report. But for the purposes of our event today, we really want a chance for everyone to network. So the findings from the Lit Review, Advisory Committee, focus groups, and interview that inform the framework include the following themes. And I don't think these are very different from what some of you have already known and experienced. So student housing and transportation, funding models differ across disciplines and organizations and even regions. Learner preparedness, things like cultural safety skills and mindset going into rural placements came up in the conversations. Workload challenges for preceptors and silos across health professional programs. There are practical challenges for interprofessional learning and community engagement when students are out in placements. And there's a need for leadership and strategic direction for rural practice education. So let's talk a little bit about the framework that was developed. And I'll start it off by talking about frameworks in general. Frameworks are graphical and/or narrative representations of interrelated events and factors, concepts, and variables that can be utilized to mobilize change. This framework describes key elements that are either hypothesized or have been found to influence change actions that occur in particular settings. And here our setting is rural practice and rural practice education. The REACH action framework is designed to be flexible and a scalable model that can be utilized across rural and remote areas in British Columbia. It describes a number of strategic directions, which are organized into 4 themes: plan and innovate, recruit, retain, and sustain. Each theme and associated strategic directions are linked to what we heard during the development process. Each theme has associated quick start actions. These are contextual, they're iterative and responsive and time bound. The quick start actions that are listed in the brief that was circulated are intended to be starting points, and they may change over time, and they're influenced by partners. Implemented together, they will strengthen the capacity for rural and remote placement opportunities for health professional students and create a network of rural and remote clinicians, academics, health service administrators, patients, and communities. This framework acknowledges that there are prerequisites and conditions necessary for collaboration, such as a common goal, trust, the willingness to share resources, a cycle of activities, community participation and guidance, and quality improvement. Collaborations are necessary across the micro, meso, and macro levels for sustainable change. So now I'll shift into looking at some of the acceleration themes that are within the framework themselves. And I'll share some of the findings anecdotally that influence these strategic directions. We heard that rural practice is different from urban, and flexibility and creativity is important to support trainees in their skill development. Many of the sites may not offer all the opportunities that are listed in a student's competency, for a particular placement. So we may need to spread those experiences over a couple of communities or different health sites. We also heard about the value of rural practice education experiences and the unique skill sets that are required for practice. I heard this from both students and preceptors. Our engagement also confirmed that students with rural roots are more likely to return to their communities and other rural communities to practice. So there's an opportunity for us to target our rural trainee. Planning and innovation strategic directions include aligning practice education with the rural healthcare context, developing a profile of the rural trainee, and enhancing supports for rural and Indigenous learners. It also includes advancing practice education models that support the development of rural healthcare providers, such as a rural health education pathway. We conducted focus groups with students, and they reported a lack of awareness of rural opportunities and incentives. Students appreciate opportunities to get involved in the community and experience what the region has to offer. They report feelings of isolation, and rural preceptors also feel additional pressure to be community ambassadors, such as a social lifeline for the students when they arrive in the community. Now, many preceptors enjoy this, but this additional responsibility is difficult to balance sometimes with other work-life demands of family and practice. Clinicians also report a hesitancy to take on students due to a lack of experience or unfamiliarity with current curriculum that the students will bring. We heard this from new practitioners as well as very experienced practitioners. So within the recruit theme, the strategic directions emphasize information sharing and a cultivation of rural interest, and you'll get a chance to see some of our work around that later today. And the importance of enhanced coordination and administration supports for rural placements, mentorship for novice preceptors, and really importantly, engagement with rural and remote communities. Preceptors report inadequate space sometimes and resources to have learners in their health spaces, and challenges balancing the demands of being a clinician and an educator with heavy patient workloads. Most report that they do not have protected time for their educational roles, and they're willingly take on the teaching role out of a commitment to the profession and for the intangible benefits of mentorship. They also report burnout and fatigue and are not necessarily willing to take on students on a continuous basis throughout the year. Students value opportunities to engage with patients and with students and clinicians from other disciplines. To continue to retain learners and preceptors in rural and remote communities, we need to create desirable teaching and learning environments. We need to establish effective communication platforms between health professionals, schools, preceptors, and students. And this, I heard loud and clear, doesn't take the form of an email. Enhance rural learning opportunities with interprofessional education, cultural immersion experiences, and training in cultural awareness and sensitivity to Indigenous and rural and remote health issues. Demonstrate a value in teaching and incentivize preceptors with time, training, support, professional development, and recognition. And the sustain theme, we heard about the importance of Indigenous health curriculum that is regional and contextual, and the inclusion of patient engagement and training experience is very valuable. Infrastructure must be in place to support multi-sector conversations and collaborations across all levels, particularly at the micro level. Addressing barriers to student participation in practice education in rural and remote communities is complex, and it really requires a collaborative action. So in order to sustain momentum, we need to continue to facilitate ongoing dialogue and a commitment to information sharing about rural practice education between learners, post-secondary institutions, health organizations, governments, and communities. We need to establish accountability mechanisms such as an evaluation plan or a reporting structure for rural and remote practice education collaborations. And we need to advocate for and reduce barriers to student participation in rural placements. We also need to prepare our learners to gain competencies and give them the opportunities to provide culturally safe care, navigate the BC healthcare system from a rural perspective, and effectively advocate for rural and Indigenous patients. So this framework provides a process guide so we can collectively engage with partners and articulate a shared understanding and facilitate some opportunities to clarify priorities that require a collaborative approach and secure meaningful action. We want to sustain communications, innovations, and accountability, and share lessons and information and avoid duplication. Most importantly, we want to celebrate our collaborative successes and to keep the momentum going. Welcome back, everyone. I'm delighted to share with you a culmination of a real collaboration with our role preceptors. We have another video that will be just in development process with students right now. In the theme of recruitment, we highlighted the need to bring awareness to rural opportunities, rural placement opportunities, also to incentivize those opportunities. So we thought what better way to do that than to hear from our rural preceptors as a message to students. So you get to hear part of this video now.
You see everything. There's a huge scope of practice. And I think people are very understanding that you don't have to be the expert. There's some really beautiful teamwork that happens and collaboration that you maybe wouldn't see in a larger center or in a hospital.
You will work with the same preceptor and the same community of doctors again and again and again, and they will get to understand what your skills, what your level of ability is faster. So they will trust you sooner.
You are one of the main practitioners here seeing the patients. So sometimes, and I want to say most of the time, my students very enjoy this continuity of care that they have for the patients.
Your scope of practice is a lot bigger in these small hospitals. There's more room to have autonomy in your practice. Everyone's voice in the room matters.
When I first had arrived, I still had this mindset that there was a hierarchy system in healthcare, and I learned pretty quickly in some acute assessments that I was working on with physicians that they actually came to me to ask truthfully what they wanted. They were really asking my opinion for the situation and taking my opinion seriously.
In general, you never know what's going to walk in the door, and at first that can be a little bit intimidating, but over time it adds like a dynamic element to our work.
I think it brings us back to the roots of medicine. We're more than just knowledge translators. We're here, we live in the community, we lead by example, we empower the families. You will have the opportunity to affect change immediately. You don't have to wait. You're ready, you're there, and you are valuable to these communities.
It's important to talk about that the framework is a process to guide our thinking, and it identifies actions that we need to take collectively, but also requires a shared accountability and commitment among the partners. Your input is valuable, and to ensure that the most impactful ideas rise to the top, we want to bring you together to talk about that. So please note this is an adaptation from the partnership pentagram. Communities does include patients, residents, industry, anyone that lives there. And we'd like to talk about how we're going to move this work forward. So we're going to break out into small discussion groups. We're going to use a technique called SOAR to guide our discussions and our analysis. It's a strategic planning technique which helps groups focus on current strengths and opportunities and create a vision for aspirations and future actions. The output from the SOAR analysis is really a set of actions that leverages strengths and opportunities and moves towards measurable results. So it provides a basis for further collaborations and sort of guides the conversation. So these are some questions that we would like you to consider in your breakout groups. What are the strengths of the framework and the gaps? If feedback welcome. What are the opportunities within your sphere of influence? What actions in the framework can be implemented immediately or in the long term? Are there additional actions that we need to consider? What I'd like you to do, most importantly for each action, is identify who the appropriate person or partner group might take the lead, and identify a spokesperson for each action. So even if you're not the one taking the lead, but you have a really good understanding of that action, we'd like that spokesperson to be identified to ensure that we represent that idea clearly in the post-symposium report, as we will link back with you all around those actions. So looking at the actions that you identify, also which results would you like to see and what does success look like? After the breakouts, we'll invite you back to report on the #1 action that you'd like to see happen, but please keep a second or third in tow in the recommendations in case another group has identified the same priority. And this will enable us to generate a list of priorities and share these across the groups through our discussion that Victoria will so nicely facilitate for us. And thank you all for your engagement and wonderful conversations. The end, as Robin and Adrian mentioned, this is just the beginning. It's a beginning and a building on previous efforts, because there's a lot of work that has been done in this area, but we want to sustain and leverage those and build momentum. So I want to emphasize, that UBC Health's role here is to facilitate and support partner groups in implementing those actions identified today, but we all have a role and a responsibility in doing that, and within our own sphere of influence, as well as within our own mandates. So to help move us forward, we're going to provide a summary report of the symposium discussions and the priority list of actions. So I invite you to continue to populate the Google Docs. I've kind of captured sort of who the spokesperson might be to help us clarify, to make sure that we get the intention of those priority actions communicated back to you in the right way. And we'll share this report with symposium participants, also those who registered and who were not able to make it for a variety of reasons, our advisory committee, and others who expressed interest but could not be with us today. We'll also send you a post-symposium survey with the summary report that will ask you for your feedback on the framework and invite you to sign up for a special interest group around the actions identified today. So we wish to help build and sustain the relationships that you've developed today. And so you'll have opportunities through the future regionally or project-focused sessions to advance the framework and implement the actions. So now I'd like to turn it over to Donna Dryden, our Director of Education for UBC Health, for closing remarks. And thank you very much for engaging today with each other and listening to me.
Yeah, thank you very much, everyone, for your engagement, and I hope you and your passion around the topic of rural education. And I hope you feel that we're at a place where we can start to really begin to sustain and mobilize moving the REACH sort of framework forward. I feel we've met our symposium aims today. We highlighted the urgent need to take action. We've increased the visibility around rural practice education and its importance. We framed an approach for you. I feel there's definitely energy, so we're catalyzing individual, but mostly the collective actions that we can take around this. I feel the momentum, and we are going to, from UBC Health, ensure that we can sustain this for y'all, and that this is the beginning of a network that will be sort of longitudinal for us all. The words I heard in the report back: trust, break down silos, the importance of local community, the importance of mentorship, support for students, virtual health, the interprofessional aspect of these rural opportunities. So I'm really excited for how we are all going to move forward. like to thank so many people. Thank Elder Cheryl Schweitzer, Dr. Ray Markham, Victoria Wood, Lubna Ekra-Madula behind the scenes, all your hard and dedicated efforts. We're proud of and thankful of our partners and teams that have produced the framework. A huge thanks and kudos to the REACH Advisory Committee for their expertise. We are indebted to our stakeholders who provided Carrie with so much information, our students, faculty, community members, administrators, clinical educators for sharing their expertise to help develop and test out the framework. Grateful to the Ministry of Advanced Education and Skills Training, Northern Health, University of Northern BC, College of New Caledonia, the Rural Coordination Center of BC, and all our health professional programs at UBC for their ongoing commitment and support of this project. And we all need to do a virtual or loud applause for my dear friend and colleague, Carrie Krakowski, for her true passion and commitment to rural health and rural education for our learners. So thank you so much, Carrie. You've done exceptional work on this. Thank you, everyone.